So before we get started with our next speaker, I have another thank you to share. In my opening comments, I mentioned that the Jenks Center is comprised of two organizations, the WSA, Winchester Seniors Association, and the Council on Aging. You may recall in past years, we talked about three organizations. The third, the Winchester Seniors Association Trust, has owned and cared for the Jenks Center building since 1976. But this year, in a great accomplishment, that trust has voted to dissolve and to combine its resources with the Winchester Seniors Association. This took a lot of work and planning, and it will result in lots of efficiency of resources, including volunteer time and finances. She's not here, but it would really be remiss to not pause to thank and acknowledge the chair of that trust for many years, who is Mary Ellen Rourke Falvey. And she's really an unsung hero, and this was a big project to help align these organizations. And there are a number of members of that board in the room as well. Would they raise their hands if you've been on the trust board? I know Carolyn Shamu was here. I see Ron Malaskis. Thank you. And all of those board members are able to join the Winchester Seniors Association board. And that brings me to acknowledging the Winchester Seniors Association board and its president, Charlie Price, who I just picked on, but now I would like to thank him. He's here pretty much every single day, and he does a great job. He's a fabulous partner for the Council on Aging. So thank you, Charlie. And if you're on the Winchester Seniors Association board, would you please raise your hand? There are a few of those in the room. And then finally, with respect to the Council on Aging, I'd like to recognize our newly elected chair, who is Nick Troisi, sitting here in the front. And there are a number of board members from the COA here. I see Cindy, Bob, David. So if you encounter any of these people while you're having lunch, thank them. They're here regularly. They help run the organizations that make the Jenks work. So thank you to all of you. And then finally, I want to acknowledge our patron advocates. They are here on behalf of all of the people who come to help us see what is needed, how we can run things better. And they are Mary Bajak and John Kowadler. Thank you both. Our next speaker is Dr. Heather Jones, and she's affiliated with Winchester Hospital. Before I share her impressive background, I would like to take a moment to say how fortunate we are to have Winchester Hospital in our midst. We have the benefits of having both a community hospital that is accessible and familiar with all of the benefits of the world-class care and treatment that we expect from Boston's medical environment. From the standpoint of the Jenks Center, we're grateful for all sorts of partnership and support from Winchester Lahey. We've received grants of health-related programs like cholesterol monitoring, and most recently, a program for the Chinese population that involves having a Mandarin-speaking healthcare navigator who will help people who don't speak English as a first language to navigate our very complicated healthcare system. We've also had speakers on topics like stroke prevention and hospital at home. The Winchester Hospital connection is one more reason why we think that the Jenks Center is such a special place. So Dr. Heather Jones has participated in a symposium here before. She was here 2 years ago to talk about superagers, and she's back by popular demand. She was fabulous. She graduated from Yale University in 1999 and from the University of Pennsylvania School of Medicine in 2003. She completed a 3-year residency in family medicine and a 1-year fellowship in geriatrics, both at the Swedish Medical Center in Seattle, Washington. She joined Winchester Family Physicians in 2007. She sees patients of all ages from under 1 year to over 100 years. She's a clinical associate professor at Tufts School of Medicine. She hosts several third-year medical students in her office every year. When she's not at work, she enjoys spending time with her children, who are 14 and 16. So when she was last here, they weren't quite all in high school yet, so I'm sure she's loving that. And she also gets to take breaks from that to walk her golden retriever. Dr. Jones's topic for us today is geriatric medicine, longevity-focused healthcare. Dr. Jones, we so appreciate your time and your expertise today. Thank you.
Thank you for having me here today. It's definitely my pleasure and my honor to talk with you all today about longevity-focused healthcare. Just a little bit more about me. So I've now been practicing right around the corner at what is now Beth Israel Lahey Primary Care for 18 and a half years. So I know lots of people here. And healthcare has evolved a lot in that period, as I'm sure all of you have lived through. I'm going to see if I can figure out how to advance these slides. There we go. So I have 3 objectives for the talk today. The first is that we are going to talk about medical challenges associated with living longer. It's not all wonderful, as you've already seen from your previous speakers. We're going to explore some ways to help patients stay healthier for longer and improve their quality of life as they get towards the end of it. And finally, to explain the importance of self-advocacy and advanced care planning. With those 3 objectives in mind, we're going to proceed with our patient case. This is not based on a real person, so don't worry about that. This is Dorothy. Dorothy is a 95-year-old woman whose daughter has brought her in to see Dr. Jones today. She has just recovered from a bout of pneumonia, for which she was in the hospital, and is mostly back to her usual self, but she's still feeling a little weak and shaky. In general, she lives in her own home by herself, but she has a hired caregiver for about 4 hours per day and a cleaning service and Meals on Wheels, so she's pretty well set up. Her daughter lives in a different part of town and provides transportation and helps out with her groceries and her finances, mostly because everything is online now and she has trouble navigating the online bank accounts and so forth. Dorothy is usually able to dress herself, manage her own hygiene, and prepare light meals for herself. She wonders, how can she fully recover from her recent illness and regain her strength to get 100% back to her usual baseline? So hopefully by the end of the talk, we can explore some strategies for helping her with this. Some statistics for you. About 2.77 million people as of 2024 data in the United States are over age 90. This number is expected to quadruple by the year 2050. So that is probably a lot of people in this audience, and then, some younger folks as well. Women in this age group outnumber men 3 to 1. And about 25% of people over age 90 live independently. There are lots of medical challenges associated with living longer. Multimorbidity, that means people have more things wrong with them, more diagnoses, more, medical illnesses. With that, of course, comes more medications. We're going to talk about a term called polypharmacy on the next slide. And of course, more specialists. Everybody has a doctor for this and a doctor for that, as well as their primary care doctor. This can be time-consuming, confusing, and very expensive. So what does polypharmacy mean? Well, I don't think even geriatric doctors can all agree on what it means. Some people say it means 10 or more medications, but the generally accepted definition is that you have 5 or more medications, prescription medications. That doesn't even include supplements. And of course, every time you add a medication, there's more risk of side effects, more risk of drug interactions. So you take one more medication. Once you add one more onto 4, then you have 5. That 5th medication can interact with every single one of those 4 medications that you're already taking. So this can be a problem. It becomes explosive in terms of side effects and drug interactions. And then other medical challenges with living longer include mobility and safety issues. People, especially in this area of the country, often have stairs in the home. This is usually fine for a while, but then can be a challenge if something happens. There's a risk of falling even if you don't have stairs. And of course, transportation and driving are a huge hot button issue. You know, how many people, and don't raise your hands, I don't really want to know, but how many people have had their children say, you should stop driving now, get some transportation, figure it out, but don't drive anymore. I've actually said that to my own dad. So it becomes a very tricky issue to navigate because, again, you know, if you're out in the suburbs, how do you get from place to place? And then you lose independence. So very tricky. All right. And finally, the medical system that we have in place now is focused on prolonging life, not necessarily on quality of life. So when you go into the hospital, the doctors that are there are only thinking about how to get this person to live longer, how to make sure nothing happens to them. Not everybody has adequate training in geriatric care and goals of care. I think that this is an issue that is being addressed better in medical schools right now, but a lot of the doctors of my generation didn't have this kind of training. So I'm very fortunate to have had that extra training in geriatric medicine so that I think more like a person who's looking at goals of care and quality of life. And then I think one of the biggest issues is that doctors right now are compensated for treating disease and trying to prolong life. For example, we get more money based on how many medications we prescribe. You know, that's a big issue in terms of coding and billing. A few years ago, primary care doctors started to say, hey, we're not getting paid like surgeons. Find a way to make us get paid a little bit more, or we're all going to leave primary care and go into surgery or dermatology or someplace where we can actually afford to stay in business. So the billing system changed, and so then they changed it so that primary care doctors actually started getting compensated for the complexity of a visit. And part of that is, how many medications are you managing? How many medications did you prescribe? That's probably not the best way to do things. So how can we help patients to live longer and, more importantly, healthier lives? So I'm going to go through some of the things that we talked about before as issues and challenges and address these things and see if there are better ways that we can manage them. So polypharmacy. I frequently have patients that come out of the hospital and they're on 3 new medications. What do we do to deal with this? So every so often, we want to look at, what is the patient taking? Do they need all of this stuff? Did they just come out of the hospital? Can we stop any of the things that were prescribed in the hospital? And then do something that I call deprescribing. Do they still need X, Y, Z? And it's a good thing to look through on your own medications and say, okay, well, I probably need this for my heart, but let me just ask about it. And maybe I don't need this other thing. So it's a good thing to do periodically, at least once or twice a year. Multiple specialists. So people sort of collect specialists as they have different problems. And then the specialists say, well, come back in a year. This can happen to any age. I will tell you a story that when my first daughter was born, she had a kidney issue called hydronephrosis. And so she wasn't prescribed anything for it. They were just watching it. And she kept going back every 6 months, and we would spend 4 hours at Children's Hospital getting an ultrasound and waiting for the urologist to be not busy. And if you've ever done that with an infant, it's really fun. And every time we went in, the urologist would say, ultrasound looks the same, see you in 6 months. And finally I said to him, well, why are we coming back? And he said, well, just to make sure it doesn't get worse. And so I fired him. And I talked to her primary care doctor, and I said, can you just manage this? Can we just get an ultrasound every so often? And then when she was 7, the primary care doctor did an ultrasound, and it was gone. But she never needed any treatment. So we probably saved ourselves, 5, 6, 7 unnecessary visits into Boston. So my point with this is primary care doctors can manage stable medical conditions that haven't changed in a while. And that's very appropriate. We don't need all of the specialists that we have sometimes. Most primary care doctors like myself consider themselves to have a medical home for patients where we try to provide holistic care that addresses everything, and we look at everything. So unless the condition is very severe or unstable, most of the time, a lot of things can be managed by the primary care doctor. Deprescribing, looking at medications that are no longer needed. For some of the things that get continued on forever that sometimes people don't need anymore are things like acid-reducing medications. Tons of people are on omeprazole, Prilosec, Protonix. Maybe they don't need that anymore. Maybe their lifestyle has changed. Maybe they're not drinking as much caffeine or alcohol, and they don't need that acid-reducing medication. So it's good to look at that and have a supervised plan to wean off of that. Antidepressants. If somebody's had a lifelong history of recurrent depression, they probably do need an antidepressant forever. But a lot of people don't, and maybe they can come off of that. Maybe something triggered their depression, the death of a partner or a close friend or sibling, and maybe they don't need that forever. So it's worth taking a look and kind of reviewing the medications and seeing if we can get rid of them from time to time. And then there are some medications that don't necessarily improve quality of life. These are a little trickier, and I would say more for the over 90 crowd. But maybe you don't need cholesterol-lowering medication if you haven't had a stroke or a heart attack. Maybe you don't need as much blood pressure medication. So these are definitely things to consider, especially towards the end of life. One example that I think is very striking is that people go into the hospital sometimes with a neurologic symptom. And, it could be something like the side of their face got numb or their arm was a little weak, and that gets immediately labeled as a TIA, a mini stroke. And then they come out of the hospital and suddenly they're on cholesterol medication, a blood thinner, another heart medication, all these different things. And then it turns out they didn't have a mini stroke after all, but nobody stops the medication. That's very common. So that's definitely worth taking a look at. Mobility and safety issues. So I think this is where a primary care doctor can be very helpful in terms of trying to address these issues. Physical therapy, balance training, these can be very, very helpful in helping people if they're deciding to stay in their own home to navigate their home and to stay there safely. Musculoskeletal disorders. That lovely x-ray is a picture of somebody who has arthritis in their knees, especially on the left side. So arthritis is a dime a dozen. Everybody gets arthritis. I just had arthritis in my foot that was fixed in December. And it's a huge issue in terms of, causing people to do less physical activity and then to have more problems with balance and strength. So these are things that can be addressed, orthopedically with multiple different modalities. And then, of course, back to our hot button issue, driving. What if somebody can't drive? I think it becomes very hard for them, both to do what they need to do and also to get to the doctor. I try to be very flexible with scheduling patients, try to see if they depend on someone for help, like a son or a daughter to get to the office, try to be very flexible with scheduling them at the end of the day, or have them do a telehealth visit. Those are some options for people who can't necessarily get into the office. And then, of course, transportation programs, like I believe the Jenks Center offers, can be really helpful in helping people navigate the transportation issue if they can't drive any longer. So I think, some take-home points from this are, we want to try to manage medical issues with less medication. So that means that we want to incorporate more lifestyle measures into treating certain conditions. Nutrition can help with a lot of different conditions. Physical activity can help with a lot of different conditions. We want to try to use these things first line instead of medications. I mentioned acid reflux and acid reducing medications earlier in the talk. And I think that's a huge one where, if you go to the doctor and you say, oh, I've had all this heartburn, the doctor can say, oh, well, here's some Prilosec, just take this forever. Or the doctor can say, well, how much caffeine do you consume? Do you like spicy foods? How much do you eat at a time? How quickly do you eat? There are a lot of different lifestyle modifications that can be used in place of just throwing acid-reducing medication at everybody. And then again, stopping medications when we don't need them anymore. So if something is under control, we can cautiously wean off of that thing. So I'm going to go over in this slide some of the conditions that improve with lifestyle modifications. And it's quite a handful. High blood pressure. Who here has been told to have a low sodium diet and exercise more, right? A lot of people. Those two things can improve blood pressure by 8 to 10 points. So I've told people, listen, I can put you on a second or a third blood pressure pill, or you can stop eating processed food and frozen dinners and deli meat, and maybe your blood pressure will come down enough with just that, and maybe even add some exercise. And we don't need to add that second or third blood pressure medicine. My mom was able to reduce her blood pressure medicines from 3 down to 1.5 by just making some lifestyle modifications. So that's a biggie. Diabetes, that's also a huge one where people can follow a diet that's low in processed foods, high in fruits and vegetables and lean proteins. And we maybe don't need to put as many, I have patients who are looking at insulin. Sometimes we don't need to add all of those things. Mental health. I don't know so much about diet for mental health, but physical activity can be really, really helpful for mental health. Getting out into nature, especially right at this time of the year when the weather is warm and it's sunny, I think that's a huge way to treat mental health without pharmacologic treatment. Insomnia, that kind of goes along with it. Physical activity has been shown, especially physical activity in the late afternoon and early evening, to have a huge impact on insomnia and improving sleep quality. I take a walk, as was mentioned earlier, with my dog. I take my walk in the evening right after dinner, about 6:30 to 7 o'clock every night. I think that has been very instrumental in helping improve my sleep quality and latency. Acid reflux, we kind of already talked about that one. And then finally, frailty, loss of muscle mass. That's a very difficult thing to define, but as people get older, they lose muscle mass. We lose about 1 to 2% of our muscle mass every year over age 40. So that's pretty much everybody in this room, including myself. And so it's really important to incorporate physical activity and especially resistance training or strength training into our daily lives. Again, the default for doctors is unfortunately to treat every illness and abnormality. This is where geriatric training comes in. This is wasteful and it's time consuming. If you've ever had a CT scan, you know that the reports could drive you mad in terms of, every little thing on the CT scan. There are incidental findings somewhere between 20 and 60% of the time, depending on the institution and the type of CT scan. Most of these things are not relevant. And of course, they lead to more tests and more consultations and more specialists. I have a friend who lives in India where they often do a full body CT scan for the heck of it, I guess. But I've seen some of these scans from other countries. It's usually high-income people who just want to make sure everything's okay, and then everything's not okay because there are 4 other things that require 4 new scans to track down the things that never were relevant in the first place. Trying to explain that to my best friend in India is very, very challenging. She's very nervous about her health in general. We're next going to talk a little bit about goals for care and advanced care planning. I think this is a big part of what I do, and it's a very important part of medical care, especially in patients who are living longer. It's very important because otherwise nobody knows what you want. In Massachusetts, the 2 things that we have as advanced care directives that are legally binding are the healthcare proxy and the MOLST form. Everybody should have a healthcare proxy over age 18. That is the person that you elect to make your medical decisions if you become incapacitated. And that could be anyone. That could be an 18-year-old in a car accident, right, who can't speak for him or herself. The MOLST form is this pink form that we have in the office that gives a little bit more instruction about, do you want to be resuscitated? Do you want to be on a ventilator? Do you want a feeding tube? Those kind of things. And it's very important to have that kind of information ahead of time because nobody knows otherwise what you want. And the default is to do everything. So if you want everything done, then great, you're all set. But if you don't, then it's really important to have these discussions ahead of time. And self-advocacy. People aren't going to do this for you. It's really important to advocate for yourself and to say to your doctor, hey, I don't think we've talked about my goals for care. I don't necessarily want to be on dialysis if my kidneys go at some point. Let's have this discussion. So that's where that comes in, and this form can be a good starting point for that discussion. Things that you should consider when you're having discussions about your goals for care and end-of-life care. What is most important to you? What makes life worth living for you? What treatments would you want or would you not want if something happened? And we never know what's going to happen to us. Why don't we talk about this? Well, I think it comes from both ends, the doctor and the patient. Fear. People don't want to talk about the end of life because that makes it real. That makes it scary. But the best time to have these discussions is when you are healthy and doing fine and everything's great. So that's when you have the time and should have these discussions. It is a very sensitive topic. I even, after 20 years doing this, have a hard time broaching it sometimes, saying, hey, I don't think we've talked about your goals for care. I don't think I know what you want if something happens to you. It's a difficult topic to broach, and not everybody wants to talk about it, and people sometimes get offended when it's brought up. So that's why it may not come up. And finally, time constraints. All of us in primary care are under huge time constraints. There's only a certain amount of time per patient, and that brings up a huge kettle of worms. So sometimes it's good to do a segmental approach where I'll say, hey, have you thought about this? Maybe think about it and we can talk about it next time. Or here's a MOLST form. This is what it looks like. maybe look it over and let me know what your thoughts are, and we can fill it out next time. But time is definitely a huge issue, especially if we have a lot of other things to talk about. Back to Dorothy. So how do we get Dorothy back to herself? How do we get her back to where she was before this hospitalization for pneumonia? Well, first of all, look over the medications that she took while she was in the hospital. Hopefully she was just prescribed some antibiotics and she's going to finish them up and be done with them. But, a lot of times people get prescribed other things. I just had a patient in the hospital for pneumonia and a COPD exacerbation. She had a new heart medication and a potassium pill started while she was in the hospital. I immediately took her off the potassium pill and said, let's check your potassium and see if you need this. And I talked to her cardiologist about stopping the heart medicine. He refused. But I still to this day don't think she needs it. The second thing is to make sure that Dorothy has adequate support while she recovers. Just, is her daughter going to be able to take a little extra time off to help her get around and make sure she restocks the house with groceries and so forth? And then she probably needs some physical therapy to get her strength back. It takes about 10 days to recover for every 1 day that you spend in the hospital when you're ill. And a lot of it is you lose muscle very quickly when you're ill. It's very tiring and fatiguing. So she might need some physical therapy. And she may need both, home physical therapy and eventually some outpatient physical therapy. My dad was in the hospital about 1.5 years ago for a hip fracture. And when he went to rehab and then he came home and he had home PT, all the normal stuff that everybody has. And he said, I'm done with home PT now. And I said, but you're not done. I said, now you're going to call your doctor and ask for outpatient physical therapy and get some balance training so that you don't fall again. That's very important. So he did that. And then finally, it's, Dorothy is 95. It's a good time to discuss her long-term care goals. Now that she's recovered, we should get some information about what she actually wants. Does she want to go back in the hospital if she becomes ill again? All right. So just some take-home points for the talk. More people are living longer than ever before, and that's only going to increase over the years. Longevity presents some very unique challenges in terms of medical care. Many medical conditions can improve without medication, with lifestyle modifications alone. And finally, when caring for older adults, doctors should focus on the patient's goals for care and improving their quality of life. And now I have some time for questions. I have one back there.
So much. Excellent presentation.
Thank
I really
you.
enjoyed it, and I've always lived in this area. I am shocked to hear about doctors and medications and that they are. Is that a statewide in Massachusetts?
That is insurance companies, and it's federal at this point, I would say. I think insurance companies struggle to figure out how to compensate primary care doctors fairly. A way to get around it is to say, this is how much time I spent with the patient, which a lot of us, I think, in geriatrics do because, but you have to have that time to spend with the patients. I'm very fortunate that I have that time. But otherwise, it becomes an insurance company issue like a lot of the other stuff in our lives.
Hi. In general, myself and friends, with all the increased number of specialists we all have, we feel like body parts. And my question to you as a primary care physician is, how do we coordinate all that? Do you mind as a primary care physician that, I email on the portal every time I see somebody else and something happens? Or what are we supposed to do so it doesn't all get tangled up?
I think that's a very good question. I get lots of emails every day. I like to hear what the update is. I usually do get an update from the specialist as well. I would say we're pretty good about coordination of care in Massachusetts, but it's confusing. This specialist adds something, that specialist doesn't think that was a good idea. The cardiologist adds something that the kidney doctor didn't like, and vice versa. It is very difficult to navigate, but I think I think you're absolutely right that you should circle back to your primary care doctor and say, hey, this person just added this. Do you think this is a good idea? I told him that I'm going to ask you first. People ask me that all the time, and I'll say, well, I think in this case they're right because, X, Y, Z, but maybe just for the short term or whatever. I definitely think it's very reasonable and appropriate to ask your primary care doctor in that situation.
Dr. Jones, thank you so very much. I think we'll have her back a third time. I don't know if others saw, there was a piece in the New York Times, an op-ed piece last week, I think, and it was about how do children have a conversation with 80-year-old parents about moving out of their home? Is their home equipped? And one of the things the article mentioned was how the medical profession, our doctor visits are not at all set up to have doctors assist us in having these conversations. And I'd just like to say, we all wish we had a doctor like Dr. Jones, because clearly she is making the time for those conversations, and the system's not really set up to facilitate them. It doesn't compensate for them. It doesn't allow for adequate time. So thank you for being such a great model in that. And we should all strive for that in our own medical care and the care of people who we love and want to live long and healthy lives.